Hello everyone, I am Dr. Shoham Mukherjee and welcome back. In our previous video, we have completed obstetrics and today I am bringing you the ultra rapid revision of gynecology in just 4 pages. I have packed all the high-yield topics you need for your FMGE and NEET PG into this one power-packed revision session, helping you to target more than 90% of the gynae questions in your exam. So if you revise this just 2 times, you will be ahead of the competition in the exam hall, it's guaranteed. The PDF for these notes are given in the link in the comment box. You can also join the Telegram group. The link for that is also given in the comment box. And like, share and subscribe for much more rapid revision focused content. If you like my channel, please do share and please do subscribe and also mention your feedback in the comment box. So let's start. Let's crack it together. So the SRY gene is located on the short arm of the Y chromosome, and if this SRY gene is present, it will form the testes at 7 weeks. If it is absent, it will form the ovary at 8 weeks. Okay. Now there are two types of cells in the testes: the Leydig cells, the Sertoli cells. So these Leydig cells will secrete testosterone, and this testosterone helps in the growth of the Wolffian duct. And Wolffian duct gives rise to the seminal vesicles, the epididymis, the ejaculatory duct, and the Vassar deferens. These Sertoli cells secrete anti-Mullerian hormone. Anti-Mullerian hormone will help in the regression of the Mullerian duct, and it will give remnants. What will be the remnants? The appendix of the testis and the prostatic utricle. Now coming to the ovary. So the ovary, it doesn't have any testosterone, therefore there will be regression of the Wolffian duct. Wolffian ducts will not be formed. And what will be the remnants of the Wolffian duct? There will be apophoron, which will be the cranial remnant. There will be paraphoron, which is the caudal remnant, and the Gartner's duct, which is the ductal remnant. There will be no anti-Mullerian hormone released, therefore the two Mullerian ducts will remain and they will give rise to the uterus, the cervix, the fallopian tubes, and the upper two-thirds of the vagina. But the lower one-third of the vagina rises from the urogenital sinus, not from the Mullerian duct. They will rise, the lower one-third, it will rise from the urogenital sinus. So that's an important thing. Now moving on to the external genitalia. So the external genitalia is due to the dihydrotestosterone. If dihydrotestosterone is present, it will give rise to the male's external genitalia, and if it is absent, the females. Okay. So the genital tubercle in the males is the glans penis, and in the females it's the clitoris. The genital fold in the males, it is the penile urethra, and in the females it is the labia minora. The genital swelling in the males, it is the scrotum, and the females it is the labia majora. Okay. Now coming to the Bartholin cyst. Bartholin cyst is very, very important. Here you can find, this is the image of the Bartholin cyst. So the Bartholin glands, also known as the greater vestibular glands, it lies in the superficial perineal pouch. Okay, the location for the Bartholin glands is superficial perineal pouch. Now the Bartholin duct, it opens 2 cm and it opens in the groove between the labia minora and the hymen. You can find it in the image. So this is the junction of the upper two-third and the lower one-third, and when these ducts get blocked, they will give rise to Bartholin cyst, which you can find in the image. Okay, what is the treatment? The treatment is incision and drainage, and the best method of treatment is the marsupialization, the best treatment, and we have to give incision and drainage and leave it alone. Okay, Bartholin's abscess is tender and the most common cause is E. coli. The treatment is again incision and drainage. Here you can find the image of the congenital Mullerian anomalies. So here this is the normal uterus. The class 1 is the uterine hypoplasia or agenesis. Class 2 is the unicornuate. Class 3 is the uterine diadelphys. So we will learn one by one what are those. So hypoplasia means both the Mullerian ducts are not formed. An example is MRKH, Mayer-Rokitansky. Okay, and it is leading to primary amenorrhea. Unicornuate uterus you can find here. Here what happens? Only one duct is present, the other is absent, and it is associated with renal anomalies. Uterine diadelphus, there is no fusion of the Mullerian ducts. Here no fusion happens. Therefore there are 2 uterus, 2 cervix, and 2 vagina. Bicornuate uterus, here this image. Here what happens? The lower part is fused but the upper part is not fused. Therefore there are 2 uterus but 1 cervix and 1 vagina, because the lower part is fused, right? The treatment for diadelphus and bicornuate uterus are Strassmann metroplasty. Then comes the septate uterus, this one. Here what happens, the septum has not resolved and it will give the worst prognosis. It can lead to infertility and abortions. What is the treatment for septate uterus? It is hysteroscopic transvaginal septal resection. And this you can find, this is the diethyl silvestrol, that is a drug related, okay. So it will give rise to a T-shaped uterus. You can find this is a T-shaped uterus and it will cause vaginal adenosis, and it can also result in clear cell adenocarcinoma of the vagina. And here this bicornuate uterus, this septate uterus may look alike, but how will you differentiate whether it is a bicornuate uterus or it is a septate uterus? So first you have to draw the lines from the two tubes, okay. Connecting the two tubes, you have to draw a line. Now if the fundus is below the line, then it is a bicornuate uterus, and if the fundus lies above the line, you can understand, right? If you are drawing a line here, if the fundus lies above the line, it is the septate uterus, and below the line fundus, it is the bicornuate uterus. What is the investigation of choice for the congenital Mullerian anomalies? It is the 3D ultrasonography or the MRI. MRI is best, and MRI is like this. In the MRI images you can do this, okay. This line you can draw in the MRI image and you can find the fundus. If it is below, it is the bicornuate, above it is the septate. Gold standard investigation is the hysteroscopy and laparoscopy. Now, this is the Leach-Wilkinson's cannula. It is used for HSG, Leach-Wilkinson's cannula. This is the image-based question. Here you can find this is the HSG of the septate uterus. This is the USG of the bicornuate uterus. So, in the HSG, how will you understand which one is septate, which one is bicornuate? So, the angle between the two tubes, here you can find it is less than 60 degree, right? So, if it is less than 60 degree, it is septate. If it is more than 60 degree, then it is complete bicornuate uterus. Now let's understand the endocrine circle in the menstrual cycle. So the hypothalamus, it will secrete pulsatile GnRH, and this pulsatile GnRH is acting on the pituitary gland to release FSH and LH. This FSH and LH will act on the ovary to release estrogen and progesterone, and estrogen and progesterone will act on the uterus. So that's the complete cycle. Now this pulsatile GnRH is stimulated by leptin, and it is down regulated by the endorphins, stress, enkephalins, all these things, okay. Now on the ovary, let's understand what's happening. So there are three phases: follicular phase, ovulation phase, and luteal phase. So in the follicular phase, what happens? There is the development of the antral follicle to dominant follicle by FSH. This FSH acts in the ovary. So there is development of antral follicle to dominant follicle by FSH. Now what will this FSH do? This FSH stimulates the granulosa cells to release estrogen and inhibin B. This estrogen and inhibin B will have negative feedback on the FSH. So estrogen, if the estrogen secretion is 200 picograms per ml for 48 hours, then it is known as the LH surge. Next, the ovulation phase, there will be both LH and FSH surge. So what's happening? You can see this is a complete cycle. This FSH will stimulate the granulosa cells to release estrogen. Now, estrogen will do what? Estrogen will make the LH surge. LH surge will lead to progesterone, and progesterone decrease will lead to the FSH. Okay, so that's a complete cycle. In the luteal phase, you can see that there will be the corpus luteum, which will secrete the estrogen, progesterone, and inhibin A. And maximum activity of corpus luteum is found on which day? Day 8. This is an important question. Maximum activity of corpus luteum on day 8. So therefore, what we are doing, we can calculate the serum progesterone on day 8 post fertilization. Suppose the fertilization is on the 14th day, so we will measure the serum progesterone on day 8 post fertilization, that is the day 22. Now this is the menstrual cycle. Here you can find the pituitary hormone levels. So FSH, it will rise in the first half. The LH, FSH, and both like the estrogen, everything, okay, the ovarian hormone levels, the LH, FSH, estrogen, all will rise on the day of ovulation. So this line is the day of ovulation. All will rise on the day of ovulation, okay. Now here what happens? Here you can also find that this is the uterine events which is taking place. So estrogen is in the follicular phase, it is the proliferative phase, and in the luteal phase, the secretory phase, both estrogen and progesterone are present. Progesterone work is what? It will inhibit the estrogen receptors on the endometrium, and you can find the difference between these two glands. Here the glands are like, the appearance of these glands is the corkscrew appearance. The corkscrew appearance is in the luteal phase, okay. And which hormone, like the serum progesterone, as I told you, which it will be the highest on day 22. So here you can find there is a spike of progesterone on day 22. Now coming to the FIGO classification of abnormal uterine bleeding. So what are the structural causes? The mnemonic for that is the palm coin. Okay, PALMCOEIN. Now the structural causes are the polyps, adenomyosis, leiomyoma, malignancy and hyperplasia, and the non-structural causes are coagulopathy. So the first line treatment for coagulopathy is tranexamic acid. What is the drug of choice for coagulopathy? It is oral contraceptive pills. Ovulatory dysfunction for OE for endometrial causes. So they will ovulatory dysfunction and endometrial causes will lead to unopposed estrogen, and therefore it will lead to endometrial hyperplasia. What is the drug of choice for that? It is again OCP. Then there are iatrogenic causes and some it is non-yet classified, and for not yet classified causes the drug of choice may be levonorgestrel IUCD. Okay, LNG IUCD. Here you can find there is a endometrial polyp. Endometrial polyp on ultrasonography will look like what? It will give a homogeneous appearance and also ecogenic. Okay. Now the clinical features for endometrial polyp are intermenstrual bleeding. So between the menstruation, between 2 cycles of menstruation, there will be bleeding. It will lead to infertility and heavy menstrual bleeding. What is the diagnosis? The gold standard is hysteroscopy. Treatment is hysteroscopic polypectomy. This is the image of adenomyoma, the ultrasonographic image, and the ultrasonographic image will show heterogeneous, not homogeneous. Okay, heterogeneous salt and pepper appearance. You can find black and white appearance completely, and it is also known as the salt and pepper appearance or the Venetian blind appearance. And what is adenomyoma? It is the presence of functional endometrium in the myometrium. If endometrium is present in the myometrium, it is known as adenomyoma. Okay. The clinical features are heavy menstrual bleeding, congestive dysmenorrhea. The observation what we'll find that the uterus is enlarged up to 14 to 16 weeks, the size of the uterus, and there will be a tender uterus which is known as the Halban sign. What is the treatment? The first line is LNG IUCD, and we can do hysterectomy. Now coming to the FIGO classification for the fibroids. So the leiomyoma subclassification system, here you can find that the 0, 1, 2, it is given the submucous. So the 0 you can find it in the image, it is the pedunculated intercavitary, and 1, this one is less than 50% intramural. So this is intramural and it is less than 50% intramural. Number 2, here you can find it is more than 50% intramural. So like that you can find it in the images. What does this mean? I hope you have already, like you are already knowing about this chart, right? So you can revise this one. So this submucous, the clinical features will be heavy menstrual bleeding. It can lead to abortion. The intramural is the most common one. Intramural, the number 4. Okay, the intramural. So this is the most common one, and it will lead to dysmenorrhea. The subserous varieties will give rise to torsion, and the cervical, the anterior cervical will what it will do? It will increase the frequency of micturition. Okay. Like the number 8, the cervical, anterior cervical, it will increase the frequency of micturition. The posterior cervical one, it will help in, like it will do the retention of urine. Now the most common degeneration what it is happening here is the hyaline degeneration. The least common degeneration is the sarcomatous degeneration, and the most common degeneration which is noticed in pregnancy is the red degeneration. Now this is the option for uterine fibroid management. So how will you manage the fibroids? If it is asymptomatic, we have just to wait and watch. We cannot do anything. We just have to wait and watch, supervise it regularly. What are the medical options available? So if there is symptomatic bleeding and pain, we have to give oral contraceptives, progesterones, oral and IUCDs, NSAIDs, tranexamic acid. For etiological treatment, we can give GnRH analogs. What it will do? It will decrease the size, or we can give mifepristone, ulipristal, acetate, danazol, all these things. The surgical options, if it is asymptomatic or it is uncertain diagnosis, pedunculated, so we can do the hysterectomy. Okay. Hysteroscopic myomectomy is done if the fibroid is inside the uterus, or if there is unexplained fertility, we can also do the surgical options. Another surgical option is the laparoscopic myomectomy. What are the non-surgical alternatives? So there is uterine artery embolization and the fibroid ablation. So if the family is complete but the lady wants to preserve the uterus, so we cannot do hysterectomy in that case. So we have to do the uterine artery embolization or the fibroid ablation. So this is the management of the uterine fibroids. Now coming to a very important topic, which is amenorrhea. Okay. So what is amenorrhea? In the absence of secondary sexual characters, there is no menses till the age of 13 years, or in the presence of secondary sexual characters, no menses till the age of 15 years, or there is no menstruation after 3 years of attaining secondary sexual characters. So if any one of these happens, this is known as amenorrhea. Here you can find, this is the image of cryptomenorrhea or false primary amenorrhea. Okay, so there can be false primary amenorrhea and true primary amenorrhea. So first let's understand what is cryptomenorrhea or false primary amenorrhea. So there can be, like, it can be due to two causes, like imperforate hymen or transverse vaginal septum. In imperforate hymen, what happens, there is the intact HPO axis, the hypothalamus, the pituitary, ovarian axis is proper, it is normal, but the menstrual blood, it cannot go out. It collects in the vagina due to the imperforate hymen. Here the blood gets collected, so it will lead to collection of blood in the vagina, which is known as hematocolpos, then hematometra, and ultimately hematosalpinx. Okay, so what will be the clinical features? There will be pain, abdomen, cyclical abdominal pain. There can be primary amenorrhea, and on peradictal examination we will find that there is a bulge throughout the vagina, and on local examination what we will find, there is a tense bluish bulging hymen. What is the treatment? We have to give a cruciate incision, cruciate shaped or a X-shaped incision. Okay, that's the treatment. Now coming to the transverse vaginal septum, so again we will find the clinical features will be cyclical abdominal pain, primary amenorrhea, but the difference from imperforate hymen is on peradictal examination we will find bulge in only the upper part of the vagina. Okay, due to the transverse vaginal septum, only in the upper part of the vagina we will find the bulge. But here what happens, here we are finding the bulge throughout the vagina. What is the treatment? It will be abdominoperitoneal resection of the septum. Now here let's understand what is true primary amenorrhea. So the most common cause is the Turner syndrome. What will be the symptoms in Turner syndrome? You all know the clinical features: the webbed neck, sensory neural hearing loss, flat chest, widely spaced nipples, diabetic mellitus, cubitus valgus, horse-shaped screw kidney, lymphedema. So all these are the clinical features you have to remember. And in Turner syndrome it is 45XO. The ovaries will be present, but it will be streak ovaries. So the gonads will be streak ovaries. Okay, secondary sexual characteristics, it will be absent. The uterus, it will be present, but it will be small. And what is the treatment for Turners? It is hormone replacement therapy. Now since the uterus is present, so you have to give hormone replacement therapy, which is a combination of estrogen and progesterone. Also the other causes may be the uterine defect. For the true primary amenorrhea, there can be uterine defects like, which is known as the eugonadotropic eugonadism, which is the MRKH. Okay, example. Then there can be ovarian defects like ovarian agenesis or dysgenesis. Here what happens, the FSH, sorry, it is FSH, okay, not FHS. FSH and LH levels will be more than 40 international units per liter. The estrogen will be less than 20 picogram per ml, and the example will be Turner's and Suez. And it is also known as hypergonadotropic hypogonadism. Let me correct this. It's FSH. FSH. Okay. Now let's come into the hypo and the hypothalamus and the pituitary defects. So here GnRH will not be released, FSH will not be released, LH will not be released. So what happens, the FSH LH levels will be less than 5, estrogen will be less than 20 picogram per ml, and it is known as hypogonadotropic hypogonadism. So in Swyer syndrome, which we have found in ovarian agenesis or dysgenesis or hypergonadotropic hypogonadism, what happens, there is 46XY. It happens due to the point mutation of the S/Y gene. Okay, and the gonads, there will be streak gonads, there will be no secondary sexual characteristics, it will be absent, and uterus is present. So what we have to do, we have to, since there are gonads, we have to do the gonadectomy, and also we can give hormone replacement therapy. Since uterus is present, we have to give estrogen and progesterone. In MRKH, it is 46XX, the ovary is present, secondary sexual characters are present, but uterus is absent. Therefore, we don't have to do hormone replacement therapy, we are doing only vaginoplasty. In androgen insensitivity syndrome, what's happening? The testosterone receptor defect is present, therefore there is 46XY. The testis is present, the testosterone is released, but the receptor is in defect. So breasts are there and uterus is not present. What is the treatment? It will be vaginoplasty and gonadectomy, plus also like after puberty we can give the, after puberty we can do the gonadectomy and hormone replacement therapy. Only estrogen we are doing, okay, no progesterone, only estrogen. 5-alpha reductase deficiency, so there is 46XY, the testis is positive, there is virilization, the uterus is negative, and the uterus is not present, and the treatment is external genitalia reconstruction. You have to remember, when you are giving hormone replacement therapy, if the uterus is positive, if the uterus is present, right, so we are giving estrogen and progesterone combined, but when uterus is not there, we don't need to give the progesterone here, we are giving only estrogen. In Kallman syndrome, there is absence of the GnRH and also anosmia is present, like the absence of smell. So also there is 46XX, the ovary is present, secondary sexual characters are absent, and uterus is also present. The treatment is what? Since there is absence of GnRH, we have to give pulsatile GnRH in a pulsatile manner. So that's the treatment for Kallman syndrome. Now here, this chart you can refer once, like how to take the history and physical examination and ultimately reach to the diagnosis. So all these diseases, the main ones, the Mullerian defects, Turner syndrome, hypergonadotropy, gonadal dysgenesis, we have already discussed here. So you can go through this again, okay? You can refer to the chart once, like how you are diagnosing it. Now coming to, after completing primary amenorrhea, we are proceeding to the secondary amenorrhea. So what is it? If there is absence of menstrual periods for at least 3 consecutive cycles or 6 months in women who have previously had menstrual cycles. So here what happened? This woman had previously menstrual cycles, but now it has stopped, okay? For how many sessions? It has stopped for at least 3 consecutive cycles or 6 months. What is the most common cause? It is pregnancy. The causes may be uterine defect, like the Asherman syndrome. What is the treatment for Asherman syndrome? It is hysteroscopic adhesiolysis, and on hysterosalpingography we will find honeycomb appearance. Ovary defects may be PCOS. It is due to the premature, like ovary defects can also include premature ovarian failure. There can be Savage syndrome. In Savage syndrome, there is FSH receptor mutation. In the pituitary defects may include Sheehan syndrome, like it is the postpartum pituitary necrosis. What is the first hormone to decrease in Sheehan syndrome? It is the growth hormone. What is the most common symptom in Sheehan syndrome? It is lactational failure. Prolactinoma, increase in prolactin. So there can be galactorrhea, amenorrhea, infertility, decrease in the libido. What is the treatment for prolactinoma? It is cabergoline. If the female is pregnant or infertile, we have to give bromocriptine, not cabergoline, okay? Now, how will you diagnose secondary amenorrhea? So we can do the urine pregnancy test. Also, we can check the serum TSH and serum prolactin levels. Then we can do the progesterone challenge test. So after giving progesterone, if there is withdrawal bleeding, okay? If the withdrawal bleeding is positive, then we can diagnose it as PCOS. If the withdrawal bleeding is negative, then we have to again give the estrogen progesterone challenge test. Now we have to combine it with estrogen. Now after giving estrogen progesterone challenge test, if bleeding is positive, then it can be Asherman syndrome, and if bleeding is negative. And if the bleeding is positive, we have to check what? We have to check the serum FSH. If the serum FSH is less than 5, that means it is the defect of the hypothalamus pituitary. And if the serum FSH is more than 40, it is the ovarian failure. So this diagnosis is very important of secondary amenorrhea. Go through this flowchart once again. Now coming to PCOS. So PCOS is the most common endocrine disorder among reproductive age of 15 to 25 years. It is the commonest cause of anovular infertility. And what happens here in PCOS? There is increase in estrogen. E1 is more it's more increasing than E2. Also, due to the increased estrogen, it will give rise to increased LH. There will be increased testosterone, increased insulin, increasing IGF-1, increased triglycerides, increased LDL. And what will decrease? There can be decrease in the sex hormone binding globulin, SHBG. So here you can find on the ultrasonography, you will find the string of pearls appearance. Here you can find there is a string of pearls like look appearance in PCOS. And here this is another symptom of PCOS. The clinical feature is acanthosis nigricans on the neck, on the axilla. You can find acanthosis nigricans. This is the Rotterdam criteria for the diagnosis of PCOS. You have to study it. Like how will the diagnosis be confirmed? It will be confirmed by 2 of the 3 criteria after exclusion of other etiologies. So first you have to exclude the other etiology. Then out of these 3 criteria, 2 have to be positive for the diagnosis of PCOS. Like the criteria are, it can be oligo or anovulation, the biochemical and or clinical signs of hyperandrogenism. So this is the biochemical sign, this is the clinical sign, this is to be present, and polycystic ovaries. Polycystic ovaries means there should be more than equals to 12 follicles. Each of them should be 2 to 9 millimeter in diameter in each ovary, or ovarian volume should be more than 10 cc, okay, 10 cubic centimeter. Now what is the treatment for PCOS? So if there is irregular cycle and oligoamenorrhea along with it, so you have to give OCP plus 3rd or 4th generation progesterone we can give. If there is obesity, what is the treatment? We can give metformin plus OCP. If there is insulin resistance, we can give metformin. If there is hirsutism, we can give OCP plus cyproterone acetate. And this is actually anti-androgenic. And if there is infertility, the first line is letrozole. We can also give clomiphene citrate. And The ultimate treatment may be laparoscopic ovarian drilling. If nothing is working, we can do this technique. This is laparoscopic ovarian drilling. Now our next topic is infertility. So it is the inability to conceive despite 1 year of regular unprotected intercourse. Despite 1 year of regular unprotected intercourse, if the age of the woman is more than 35 years, it will be 6 months. Okay, normally it is 1 year, but if it is more than 35 years, then it is 6 months. The causes may be female. Due to the females, it can be 50% of the causes. Male may be due to 40%, and unexplained causes are 15%. Unexplained fertility means after everything, the cause is still not found. So it is unexplained infertility. It is 50%. And female causes may be due to hypothalamus pituitary failure, which is the Kalman syndrome. It can be due to PCOS. It can be due to ovarian failure. It can be due to hyperprolactinemia. What is the treatment? It is ovulation induction agents. So clomiphene, which is a selective estrogen receptor modulator. It can be letrozole, which is an aromatase inhibitor, and gonadotropins. We can give injection of human menopausal gonadotropin. What are the ovarian indicators? So the direct indicator is the laparoscopic visualization of corpus luteum. And indirect, it can be the Michelmer's pain, which is the mid-cycle ovulatory pain. Also, the increase in basal body temperature or cervical mucus changes. So what will be the changes due to estrogen? We will find the cervical mucus will be thin and copious. The skin bucket phenomena will be present, and there will be furning. Whereas in progesterone, there can be thick and scanty cervical mucus, and there is no furning present. Okay. And if we give this ovulation induction agents, what will be the side effect if this is given in excess? It can lead to formation of twins, it can lead to ovarian hyperstimulation syndrome and epithelial ovarian cancer. This ultrasonography image is for the ovarian hyperstimulation syndrome. Okay, here you can find the ovarian hyperstimulation syndrome. This image is very, very important. Now the male infertility, we have to do the sperm analysis. The sperm volume has to be 1.5. The sperm concentration should be 15, total motility should be 40, more than 40, progressive motility should be more than 32, the vitality should be more than 58, like this, the pH should be more than 7.2. So all this, the sperm morphology, this chart you have to remember. The sperm analysis. What is aspermia? It is the absence of semen. Azoospermia, it is zero sperm count. Then asthenospermia, it is less than 40% of the motile spermatozoa, and oligospermia, it is if the sperm count is less than 15 million per ml. Now coming to a very important topic, which is oncology, the cervical cancer. So I am discussing only the cervical cancer. If like this is must, okay, cervical cancer is must. Questions will come from here. If you want, you can study the ovarian cancer and all. Some important points about those, but I am discussing the cervical cancer here. This page is completely about cervical cancer. You have to revise it the whole, okay? Every point you have to remember here. So cervical cancer in situ. So how will you screen it? With the help of pap smear, liquid-based cytology. Here you can find the image. The liquid-based cytology brush is there. And HPV DNA testing is the best method. Also you can do VIA, VILI. Okay. This image is the IAT spatula. This is the liquid-based cytology brush. Now for 30 to 50 years, how will you do the screening? We have to do the HPV DNA testing every 5 to 10 years. And if the woman is HIV positive, then we have to start the screening at 25 years. And HPV DNA testing should be done every 3 to 5 years in that case. The WHO approach, the triple pillar approach, the 90-70-90, what is that? The target is to eliminate CA cervix by 2030. So 90 means 90% girls less than 15 years should be vaccinated. 70 means 70% women aged around 35 to 45 years should be screened. And 90 means 90% with CIN cervix should receive the treatment. So that's the thing. Now coming to the stages, so CIN1 includes the lower 1/3 of the epithelium will be dysplastic. CIN2 means lower 2/3 of the epithelium will be dysplastic. CIN3 is more than 2/3 of the epithelium will be dysplastic, and CIS, carcinoma in situ, means the entire epithelium plus like the entire epithelium is dysplastic and there is no breach in the basement membrane. How will you confirm the diagnosis? With the help of colposcopy. So if there is a visible lesion, we can do punch biopsy. If there is a microscopic lesion, we can do colposcopy, and if the lesion is endocervical, we can do cone biopsy or conization. Okay. What is the treatment? So the treatment for CIN1 is, it will, like the 60% cases, it regresses by its own. We can take the pap smear and HPV DNA test every 6 months. So regular monitoring is required. For CIN2 and CIN3, loop electroexcisional procedure. The short form for that is LEEP, LEEP. Okay, it is the best. Like for any age of CIN2, CIN3, you do not have to see the age, just mark the answer loop. Leap. It's the loop electroexcisional procedure, and like you will excise the cervix. And for recurrent CIN3, we are doing hysterectomy. If CIN is extending into the vaginal fornices, we are doing laser ablation or hysterectomy. This is the stage for CIN. You have to remember this stage. This is important. Questions will come. So stage 1 is invasive carcinoma, which is confined to the cervix. Stage 1A is, it can be diagnosed only by microscopy. Stage 1A1, it is microinvasive carcinoma with stromal invasion less than 3 mm depth. 1A2, less than 5 mm depth. 1B is clinically visible. Now. 1A was microscopically. 1B is clinically visible. 1B1 is clinical lesion less than 4. 1B2 clinical lesion more than 4. Stage 2 is extension beyond the cervix but not to the side walls, that is the upper 2/3 of the vagina. 2A is involvement of the upper 2/3 of the vagina without parametrial involvement. In 2B there is parametrial involvement. Stage 3 is extension to the pelvic wall or to the lower third of the vagina, and there will be hydronephrosis also. Stage 3A, there is involvement of the lower third of the vagina without the lateral pelvic walls. Stage 3B, now the lateral pelvic wall is also involved. Also there is hydronephrosis. Stage 3C1, there will be spread to the pelvic lymph nodes. 3C2, para-aortic lymph nodes. Stage 4 is extension beyond the true pelvis, and now it involves the bladder and the rectum. Stage 4A, there is involvement of the bladder and the rectal mucosa. Stage 4B, there is spread outside the true pelvis or there is distant metastasis. Now these are the symptoms of the cervical cancer: pelvical pain, anosal vaginal discharge, lower back pain, pain during intercourse, vaginal bleeding after the intercourse, vaginal bleeding during the menstrual cycle, longer or heavy menstrual periods than usual. What are the signs? So the cervical cancer will be fixed, it is hard, it is indurated, friable, and it bleeds on touch. So these are the signs and symptoms of cervical cancer. What are the complications of cervical cancer? There will be pyometra, uremia, fistula, and this uremia is the cause of death in cervical cancer. What vaccines we can give? Gardasil, which is for HPV 6, 11, 16, 18. Gardasil L, so it is also for 6, 11, 16, 18. And Cervavac, this is the Indian version of Gardasil. This is the L1 capsid protein, okay, and this can be given for HPV 6, 11, 16, 18, 33, 45, 52, 58. What is the treatment for 1A1 to 2A1? We can do the surgical treatment. For 2A2 to 4B, we can give concurrent chemotherapy with the help of cisplatin, then radiotherapy. 1B1, 1B2, 2A1, type 3 hysterectomy plus pelvic lymphadenectomy. 1A1, 1A2, type 2 hysterectomy plus pelvic lymphadenectomy. And for Cervavac, what is the dose? So if it is less than 15 years of age, if the age of the woman, then we have to give 2 doses at 0 to 6 months. And if the age is more than 15 years, we are giving 3 doses at 0 months, 2 months, and 6 months. Now coming to an important topic, which is the pelvic organ prolapse. You can find the images. Here it is the arrow marked is the anterior vaginal wall prolapse. First learn the anatomy here. You can see the anatomy, the uterus, the bladder, the urethra, the vagina. So here it is the anterior vaginal wall prolapse. Here what happens, this is the urethrocoele. This is the posterior vaginal wall prolapse. This is the enterocoele. The intestine is coming out, prolapsing, okay. This is the uterine prolapse, the uterus is prolapsing, and this is the vaginal wall prolapse. So we have removed the uterus and the vagina remains, okay. So that's the thing. Now coming to the treatment of the prolapse. So for older patients and family is completed and the patient is fit for surgical treatment, then we are doing the vaginal hysterectomy. For cystocele and cystourethrocoele, we are doing anterior colporrhaphy. For rectocele, for rectum is coming out, we are doing the posterior colpoperineography. For elderly and such patients who are not fit for surgery, we are giving pessaries, and ultimately we can do the Lefort surgery. For young nulliparous women, we can do sling surgery. For multiparous women, we can do the Fothergill's and Manchester surgery. For enterocele, we can do McCall's scaldoplasty. For vault prolapse, this one we can do the sacrocolpopexy. Now this is the vesicovaginal fistula. Here you can find there is a fistula between the vesico means the bladder. Here this is the bladder. There is a fistula between the bladder and the vagina. So the vesicovaginal fistula. The most common cause in India is the obstructed labor, and most common symptom, there will be continuous dribbling of urine from the vagina, and there is no voluntary micturition. Since all the urine has dribbled out from the vagina, there is no voluntary micturition, okay. There is no sense of micturition. The patient will not go for micturition voluntarily. And what is the investigation of choice for vesicovaginal fistula? It is the cystoscopy. The treatment is If it is detected within 24 hours, then we can repair it immediately. If it is more than 24 hours, then we can repair after 6 weeks. The surgery is the Latchko or the 3-layer technique. And what is the, like, after post surgery, the woman should not undergo sexual intercourse for 3 months, no pregnancy for 1 year, and catheterization for 2 weeks. And ultimately our last topic, which is the vaginal infections. So these are very important, these 3: vaginal bacterial vaginosis, the Gardnerella, the Candidiasis, and Trichomonas. So in bacterial vaginosis, the pH should be more than 4.5, candidiasis less than 4.5, and trichomonas more than 4.5. What is the discharge in bacterial vaginosis? It will be grayish white milky discharge, foul smelling discharge, which will give fishy odor. Candidiasis, there will be curdy discharge, okay, candidiasis D, curd. The name only you can match. The order will be intense pruritus, and trichomonas, there will be greenish, profuse, purulent, frothy discharge, foul smelling discharge, greenish, profuse discharge in trichomonas. On microscopy, we will find increased number of clue cells in bacterial vaginosis. Clue cells, there will be increased number of Gardnerella vaginalis and other organisms. There will be reduced lactobacillus and reduced leukocytes. In candidiasis, there will be yeast-like fungal elements of budding yeast or mycelia. There is slight increase in the number of leukocytes, and in trichomonas, there is increased number of motile trichomonas, increased leukocytes. Okay, so leukocyte number is increased in trichomonas, and candidiasis, there is slight increase, but it is reduced in bacterial vaginosis. What are the other characters? So for bacterial vaginosis, we have to do the Amstel's criteria, which says that the pH should be more than 5. There should be grayish white discharge. On Whipp's test, so Whipp's test, what we are using addition of 10% KOH to the vaginal secretion, and then it will release a fishy amine-like odor. So that's the Whipp's test positive. Also, the clue cells should be more than 20%. Now, what is the treatment of choice for bacterial vaginosis? It is metronidazole, and here you can find the grayish white discharge, okay, this discharge. Now, cardi discharge, this is due to the candidiasis, and it is seen in immunocompromised host. What is the treatment? Fluconazole. And this one is the Trichomonas vaginalis. You can find a greenish, purulent, frothy discharge. So here, what will be our characteristic features? There will be strawberry vagina. Strawberry vagina, if it is in the question, it is a hint for trichomonas. There will be multiple small punctate strawberry spots on the vaginal vault, and there will be portio vaginalis of cervix. What is the treatment? It is again metronidazole. So metronidazole for trichomonas and bacterial vaginosis, and for candidiasis it is fluconazole. So those are the high points of gynecology. We have covered it in 4 pages. In the previous video, you can find obstetrics. It was again in 4 pages. You can take the PDFs. The link for the PDF is given in the comment box. Also, I have covered, except this gynecology and obstetrics, okay, this is my 13th subject. I have covered 12 subjects earlier. So 12 subjects are already covered. You can watch these videos. It will not take you much time. You can cover all the 12 subjects. If you study the notes also, if you refer my notes for the last minute revision, you can complete it in 3 to 4 hours. These notes will not be more than 150 pages. It will be within 150 pages, all these 13 subjects. And you know what's the most important benefit for this? You can carry these notes to your exam center. Like you are traveling, you can study on the go. You are standing in front of the exam hall, you are in a break between the 2 parts, you can revise this exam notes. These exam notes are so portable, and these are so small. It carries only the high yield points. There is like no concept building. You have already studied for so long, you have attempted so many coachings. Now you just need to revise and revise. So these notes will help you revise multiple times. And if you have any queries, you can reach out to me on Instagram. You can follow me on Instagram. This is my Instagram ID. And yes, you can join my Telegram group. The link for that is in the comment box. And also the PDF, the notes PDF, you can get it from the link which is in the comment box. Okay, thank you.